Good morning, ladies and gentlemen. I know it's only 7:45, but hopefully I have a perfect topic to wake you up. How fusion and navigation solution can help to push the boundaries of ultrasound-guided interventions. And it's true that as interventional radiologists, we do love ultrasound guidance. It's cheap, it's easily accessible, you have real-time imaging without any radiation. However, it has also some limitations, and if I'm showing you this case and ask you if you can biopsy that using ultrasound guidance, I think that you will all agree that no, it is definitely impossible. And why is that? Because this is an extreme case, but in the daily clinical practice, you can face these two major issues of ultrasound guidance: poor visualization of the target lesion, as in this case you can see you can barely not identify the renal tumor, and also poor identification of the needle, which can be problematic. So what are the solutions? If you want to stay and keep working in the ultrasound suite, the solution to identify the lesion is to go for mental fusion. And this is how it looks like in real life. You look at the ultrasound, at the CT, you concentrate, and then you try to do yourself the fusion, but it is not really effective and it's a little bit old-fashioned. What about looking at the needle? Here again, there's a solution that we have all been performed. It's shaking hard the needle, as the patient was your worst enemy. But again, there are better solutions today. Another way to do is to switch to other imaging modalities, such as CT, CBCT, and even MRI or PET-CT today. But you have problems regarding cost and accessibility to these modalities. So there might be a third way. And if we look at the new ultrasound machines offered by Toshiba, there are softwares which might help the radiologists to perform better interventions. And this is what we are looking at: fusion and needle tracking. So again, this is a clinical example, a lung mass which has a pleural contact with a small acoustic window there. So this lesion might be accessible to ultrasound using a microconvex probe. Again, this is what you see in real life, so it can be problematic, first of all, to see the lesion. So one solution could be to use this fusion facilities. So here we perform the fusion using the 12th rib as a fusion point, and then you can see I'm able to identify the tumor. So it's easier for me to target something I can see. Let me explain a little bit how fusion works. So with fusion, the machine will automatically align both CT or MR DICOM images from a prior examination to the live ultrasound. That means that you can see during the intervention, this is an example during an adrenal biopsy, you can see here the electromagnetic sensor which has been covered sterilely. And even though I have a codocranial access here, you can see that the machine will automatically link the CT to the ultrasound live. So there is really no delay in between the two images. What about the precision? We have done a small study to compare the real coordinates on CT and the virtual coordinates calculated on the fusion imaging with the patient lying under general anesthesia and the CT scan performed in the same position as ultrasound. And you can see that the mean difference was less than 5 millimeters, so quite acceptable to perform an intervention. The difference might be a little bit higher if the CT has been done in another position than the ultrasound, or if the patient is not under general anesthesia, because it will move a little bit more. The second issue, visualization of the needle. Here again, you see my axis will be quite parallel to the ultrasound beam. The soft tissue are quite hyperechoic, so I might be in trouble to identify my needles. So another solution might be to use smart navigation. You can see here, the machine displays exactly the position of my coaxial needle. That means I'm doing the biopsy from this point, and I'm correctly targeted. You can see that there's a little bit of misregistration for the fusion imaging, because the patient moved a little bit in between the first ultrasound and the realization of the navigation. But however, I know that the tumor is there, so I have all the information to perform my procedure. So how navigation works? You just have to fix this small sensor to the proximal part of the needle, and then the machine will be able to show you exactly where your needle is. So this is an example on a phantoma. You can see here the needle with navigation in the plane. The line is green. And when I will be out of the plane, I'm not in the axis of the needle, the line will become red or blue, depending if you are too high or too low. And also the circle here goes bigger, meaning you are not looking at the tip of the needle. This is a clinical example for liver biopsy. You see I have some trouble to identify the needle in the subcutaneous tissue, so I can use the needle tracking. Here I'm in the plane, and once I will be in the liver, I do not need needle tracking anymore because I know where I am. And you can see one of the small issues of the system is that there might be some shift between the tip of the needle there and what the navigation system shows me. And why is that? It's because the sensor is only outside the patient. I mean, if you bend too much the needle, you might be mislocated with the navigation system. So there's a little bit of learning curve to take. So when you correct the direction, you have to do it gently without bending too much the proximal part of the needles. It's just a matter of habitus. So what about combining these two techniques, using fusion and needle tracking? To my point of view, it gives you something which is more than just ultrasound. And let me explain myself with some clinical examples. First case, mediastinal mass, which is sent for biopsy. So typically the kind of mass I think you would go for CT guidance. What about using ultrasound guidance? If I use a microconvex probe, maybe I have a small acoustic window there. This is how it looks like with ultrasound alone. So you have probably the pulmonary artery there, and probably this is the mass. I'm not sure you would go for a biopsy just based on that. It's maybe feasible, but it's better to be more confident if you want to perform this conveniently. So again, doing the fusion imaging based on the sternal point, the higher part of the sternum, you can see that right now I am much more confident. I can see the mass. You can even see the cystic part of the mass and the small calcification there with a perfect registration between the two images. Now let's go to the biopsy. The problem here, I have the sternum, so there will be shadowing of the ultrasound beam, meaning I will not be able to see the tip of my needle behind the sternum, which can be problematic because I might puncture the aorta, which is not really what I want to do. So again, using navigation software, yes, you can see here, this is my needle. I'm right now in the plane, it's green. This is the tip, and you have to look at the registration of the images. You can see this is the pulmonary artery, which is nicely correlating on both images. That means my fusion is good, I know that navigation is good, and I'm correctly targeted. So again, you clearly improve the confidence in your intervention. Another tricky case, you can see that the bone marrow here is clearly abnormal. What about doing that with ultrasound? The CT room is not free, you want to hurry a little bit. This is what you see using ultrasound alone. So it's not really nice picture, a little bit foggy. If you use fusion imaging, and here it was done on the highest part of the sacrum, this is what I see. So I can clearly identify the iliac wing there. I know this is the sacral wing. Now the problem is, if I put my bone trocar inside, I will not see it. So again, maybe navigation can help. And you can see there, this is the bone trocar, this is the tip of my bone trocar. So based on fusion and navigation, I know I'm there. And then I can advance completely inside the bone and do something which is, I think, not really feasible with ultrasound alone. So this was for biopsy, but we stand here in ECIO 2016, and I think we have to speak about ablation. How can these technologies help to improve the quality of your ablation? I will show you two cases of liver ablation because liver is the organ I think we target the most using ultrasound guidance. First case, this is a recurrent HCC. You can see a previous RF scare. There's a new HCC here on the edge of the RF scare. And based on CT, the perfect approach would be intercostal. The problem is when I'm imaging the patient with ultrasound, with an intercostal approach, I cannot really see the tumor and I do not have a nice access to the lesions. So the best way for me is to go with the subcostal position of the ultrasound probe and an intercostal positioning of the microwave probe. So here again, using both modalities helps me. First of all, using fusion because on ultrasound I cannot see the tumor. And you can see here again, I have to pay attention of the quality of the fusion, meaning I'm just checking that the vena cava is nicely correlated. The aorta is perfectly fused. If you look at the fatty lines of the liver hilum, again, you have a nice fusion. That means that if I go there, I will be inside the tumor. And here also, navigation helps me, because when you are out of the plane, if you are in the subcutaneous or muscles, you might be in trouble to identify the needle. Once you're in the liver, it's easier. But before, meaning in this part of the patient, you might be in trouble. So using navigation helps me to locate correctly my needle and to position it really inside the tumor and change something which is, I think, hardly or not feasible with ultrasound alone to something feasible. Another case which is quite similar, subcostal approach and intercostal, subcostal approach for the ultrasound examination and intercostal positioning of the probe. Oops, sorry. There might be a video. Again, fusion helps to identify the tumor, and navigation helps to identify my needle, especially when I'm here and I cannot really see it. And the other interesting point is once you have done the ablation, you know that you will have some gas around the needle. So when you want to do the tract ablation, navigation helps because you will see the needle. When I withdraw the needle, you will see the tip and you will see when you have to stop to coagulate the tract. So quite interesting to use this system. Now, I've been talking about using ultrasound alone. What about moving the ultrasound to the CT suite? It might help also. I just show you this case. So this was a recurrent breast metastasis, single metastasis, so we had to go for curative ablation. This was the first session of treatment using cryoablation, and here in that case, the lesion was superficial. We positioned the cryoprobes using ultrasound guidance and then monitor the ice ball with CT. Okay, everything went well, but 4 months later, the patient comes back, and you can see there is a new tumor here in the second intercostal space. The problem is I can see it on PET. You can see a small contrast uptake on MR, but you cannot see anything on CT. So you might be in trouble by using CT alone, and by using ultrasound alone, you might also be in trouble because the lesion is really located close to the brachial plexus, and you have to look for the ice ball, which is not really feasible with ultrasound. So again, you can use ultrasound to target the lesion. And the first ultrasound, I was not able to identify the tumor. So again, going for fusion, and you can see that the small contrast uptakes corresponds to this lesion. So I'm able to locate the lesion, and so I'm able to target it. The problem is, when I was using my cryoprobe, I could not really see it. So I've been activating the navigation, and again, you can see that the tip of my cryoprobe will be positioned correctly within the tumor. And it's quite easy then to perform the puncture. Once you have done that, remember the case. Whoops. Okay. So this is the tumor. You have the brachial plexus and the axillary artery and veins just above. So I need to push that away. And for that case, I need CT scan to perform the hydrodissection. And you can see the small 20-gauge needle, the hydrodissection using saline with contrast. And then I will be able to monitor the ice ball and to look that the brachial plexus stays away from the ice ball, and you see the vessels have been pushed back to limit the sink effect. So clearly, in this case, again, you change a treatment which would be difficult using either ultrasound or CT alone to something really not easy, but clearly feasible using both modalities together. So at the conclusion, I hope I've convinced you that using these new modalities is really can help to push the boundaries and open new windows for ultrasound-guided interventions. And if you remember the first case, the iliac bone biopsy, well, probably I can try. Smart fusion, based on the sacrum, lesion should be there. Then I'm using navigation, the bone trocar. I know the tip of my needle is there. I'm advancing it slowly. I might be correctly targeted. And for that patient, we did a CT to prove that it was correct. And you see we are inside the lesion. So it might be feasible to do something which was not feasible before, because if you remove navigation, this is what you see. Impossible, I think. Completely impossible. And I would like to thank you.